going. Okay. So when you're writing up these induction agents, that, you know, okay, for example, apnea with propofol is very common. I don't necessarily, is it a side effect? Yes. Would it be a contraindication? Probably not. We can treat it. I can accommodate for apnea because you can have oxygen on standby. You're probably putting an endotracheal tube. You can bag the patient, and the apnea, as long as you're using appropriate dosing and you've not done like a major overdose, apnea is common even at normal dosing and normal administration, but it usually goes away. So that's definitely a side effect of propofol. Hypotension is a side effect. And then if a patient was going to have an adverse reaction, the apnea might be lasting longer, or the hypotension might be lasting longer, and you have to treat it with fluids and such. Hold on one second. Okay, so some of this, yes, they are all, you don't have to write up the categories. You don't have to write up hypnotics. You don't have to write up barbiturates. You don't have to write up any.
Hello?
Hey, somebody needs to come in and get the dogs. Bo's digging and AJ's crying. So somebody needs to come get the dogs.
Okay, I'll come get him.
Okay. So what we're going to do, let me talk about another category of drugs. And we're going to talk, hey, Gabe, you may have to put AJ on a leash or watch him. Okay, so we're going to talk about the barbiturates. Now, barbiturates are it's a very large class. They are controlled. They basically aren't used much anymore. I don't even know if you can get them. I think in some research hospitals, they still use them. The one category used for anesthesia is the ultra short acting. Okay, let me explain. When you look up barbiturates, there's 3 groups. There's the long acting barbiturate, which is phenobarbital, and that's used for seizures. Okay, some people say you can use them as sedatives. I've only ever seen phenobarbital used for seizures. Now that's a long-acting barbiturate. There's also a short-acting barbiturate called pentobarbital. And this can sometimes be used for a short-term treatment of seizures. This is actually your euthanasia solution. In euthanasia solutions, it's higher doses. Okay, so actually, if you look up what euthanasia is a short-acting barbiturate, but it's in a different concentration. The only barbiturate we used truly everyday anesthesia was pentothal. And the only reason I really bring it up is because a lot of times this stuff is on the board exam. So they'll still talk about it on the boards, because basically when I was at Purdue, pentothal was our major induction agent. We used pentothal for almost every patient. You give it IV, and it basically would kick in, would induce anesthesia. The thing that you need to understand, and it's not on this slide, about pentothal is that it accumulates in the tissues. So if you wanted to give another dose and another dose and another dose, it would accumulate in the fat. So some of it goes to the blood, some of it goes to the fat. What happens is when blood levels drop, the fat would release pentothal. Pentobarbital is for euthanasia, Miranda. Phenobarbital is seizures. Pentobarbital is euthanasia. Pentothal is for anesthesia. Long-acting, short-acting, ultra-short. Ultra-short was the anesthetic barbiturate that we used. Pentothal accumulates in the tissues. It was also caustic to the tissues. If you got it outside of the catheter, if the catheter was bad, or you went to hit the vein and it went outside of the vein, it could cause sloughing at the site. You had to flush the site. We had to do hot packs. So pentothal actually could cause some damage to the tissues. Like you can get propofol out of the vein, alfaxin, most of the other agents, if you get out of the vein, you would just, the dog might lick it, or there might be like a little bump, like a little bleb, but it wouldn't cause any permanent tissue damage. Okay. But the other thing is that you cannot redose, or you could run into an overdose. Whereas, like when I talked about propofol and alfaxin, you can give repeated dosing and they do not accumulate. So that's important to understand about the barbiturates. And we did not use barbiturates in greyhounds or sighthounds, really, because what happens when you give a dose, they don't have that fat component. Okay, so what happens in a greyhound, I used to tell students, it goes blood to brain to fat. Some is in the blood, some's in the brain, some's in the fat. So basically, a greyhound, if they're lacking the fat component, then what happens is you have more available in the blood and the brain, and it would keep recirculating and redosing. So they could sleep longer. They usually had extended recoveries. So we used other drugs. But it was kind of exciting in sighthounds when propofol came out, because propofol didn't act like that. So right now, once we got propofol, that was my drug of choice, or ketamine Valium in a sighthound. So there are some notes underneath here. Like I said, I don't even know if you can obtain I don't think you can get thiopental anymore. Maybe you can get it in research. Okay. Now, the dissociative category is basically, well, there's phenylcyclidine, but really ketamine is the main drug that we use in veterinary medicine. Now, this is where it gets a little confusing. If you wanted to use ketamine by itself, remember I said sometimes you have that mean cat, you maybe had to groom it, maybe you had to draw some blood, maybe you had to take some x-rays. You can use ketamine by itself. The problem is it makes them extremely rigid. They're like a board. It's almost like you could stretch them out and flip them over like a flat board. There is not good muscle relaxation with dissociatives. That's why we usually give ketamine with something. So very rarely do we use ketamine by itself. The only time would be if you needed to restrain something, you could do that. So typically we mix it with other drugs. Hang on one second. Bo! So they took the puppy out and left Bo inside, and now Bo is not happy.
Hello?
Can Joey come get Bo or something? He's crying and digging.
Oh my god, we need Bo too?
Well, he's just, I'm trying to talk and he's like crying and digging at the board.
Alright, I'll get him.
Thanks. Okay, so if you want to mix ketamine and ACE, now remember, ketamine, it causes rigidity. ACE promazine is a sedative, so you get some enhanced sedation, you would get some muscle relaxation. Ketamine ACE is more appropriate for like a grooming, some x-rays, not surgery. Ketamine ACE would be like just something very minor. Ketamine morphine would give you some analgesia, but morphine doesn't have a lot of sedation. So we really need to mix ketamine with some more potent drugs. There are people, and I'm just going to add, ketamine has some analgesia. The main reason you use ketamine is for immobilization and loss of reflexes. But you can do low dose ketamine in like a CRI. At a VCA, they do what's called an MLK CRI. It's morphine, lidocaine, and ketamine. And they do it as a drip in their fluids. And ketamine at what we call sub-anesthetic dosing, meaning it doesn't induce anesthesia, can give you some analgesia. In people, they are using a nasal form of ketamine to treat depression. It's kind of interesting. It wouldn't be an anesthetic level of ketamine, but nasal ketamine is starting to be used in people for, very, you know, like these depression cases. You can squirt it in the mouth too. If you have a very mean cat that you can't get an injection in the muscle, you can squirt it in the mouth and for a feral cat. And it is controlled. So the other one that we talked about is tyletamine is combined with zolazepam, which is tilazol. So tilazol is considered a dissociative because it has this tyletamine in it, which is tyletamine, ketamine. Zolazepam, diazepam. So do you see the similarity? Tilazol is the TEL, tyletamine, ZOL, zolazepam, tilazol. So if that helps you remember, tilazol is used, you can give it IV, but the advantage to tilazol, it's an IM. Sometimes they will add an analgesic like morphine or hydromorphone to it. It is a controlled substance, but what I want you to put a note for this slide number 80 is tilazol is really for aggressive patients. It's also good for swine. If you're going to be working with pigs are also used a lot in research. So you might not be on a farm, you could be working in research, and swine are very similar to people. So sometimes swine make a good research model. Tilazol would be under your dissociative category, and you can look up tilazol. Tilazol is in your plum, and you would write up, I just want you to know when you write up tilazol, it's primarily under the dissociative category, but it has its own effects. The advantage, and I'm telling you the advantage, I am not a tilazol fan. I don't really like tilazol a lot, but it is good if you have that very aggressive patient because you can give one shot in the muscle and it pretty much induces them, IM. You can usually intubate them and handle them. So it would go under that category. But let me talk about the dissociatives in general. What do they do? The way these drugs work is it disrupts the nerve transmission in the brain. And it causes some stimulation to the brain. But what it does, it's kind of like an uncoordinated impulse. The way I think about it is it does inhibit windup, which is this pain response. When they feel pain and we don't treat it, it continues to modulate and increase, and it's called windup. So tilazol or any of the dissociatives or ketamine disrupts that. It's almost, the way I think of it is like they know potentially something's happening. They can't quite formulate a proper response to it. They look like they're in a trance and they look like they're awake, but they are immobile and aware of their surroundings. So here's a picture of a cat on ketamine. They're kind of like, so think about in their head, they may realize they're being groomed. They may realize you're taking x-rays or doing whatever, but they just can't quite react to it. But they have this very bored, like these legs are usually fairly stiff when they're just on ketamine. With tilazol, you get more relaxation because it's mixed with zolazepam. So tilazol, they should be relaxed, but ketamine, correct, right? That means they're kind of like they're there, but they're not, when they're unaware of their surroundings, it's like they look like they're looking, but they're not really sure of what to do or how to respond. That's basically what that means. So you can see that they look like they're in a trance state. Now, when you give ketamine, now this is talking about ketamine by itself. Again, when you add it with other agents, it may alter this, but usually 1 to 2 minutes after an IV injection, they should be handleable or intubatable, maybe 10 minutes after an IM injection. So IM is going to take a little bit longer. Basically, if you increase the dose, it is going to prolong how long it lasts, but it doesn't make them go deeper. It's basically just going to prolong its action. Now, the other thing is they are either metabolized in the liver, excreted unchanged in the urine. So if you have an animal with liver or especially kidney disease, you have to use ketamine with caution. Think ketamine, kidney, KK, ketamine, kidney. I want you to put a note here for slide 83. Ketamine is excreted unchanged, about 50% of it in the dog, but about 90% in cats. In cats, they pretty much, 90% of ketamine is urinated out, active. So that means that the active drug has to be urinated out for it to be cleared from the body. So we know if I have a cat with kidney disease, if I use ketamine and they do not have normal kidney function, that drug is going to stay in the system and potentially recirculate and keep them deeper. That's my worry when I used to say, and you've heard me before, Michaela, about 50% of dogs exchange it in the kidney or urinated out, 90% in cats. So a dog, some is going to go to 50% will go to the liver, will be maybe broken down, and 50% of it is urinated out. In the cat, only about 10% is going to go through some liver metabolism. 90% of it's going to be excreted in the kidney. So again, if I have a cat with kidney disease, I may want to choose another drug because normally what that means is my cat, that anesthetic dose is going to last longer. They may sleep longer, take longer to recover. They're going to have a more profound effect. Now, dissociatives have very unique effects on the nervous system, basically cataleptic state, which is kind of like a sleepwalking or like paralyzed look about them. They retain their reflexes longer. This is going to be important because I'm going to talk about when we choose this drug and when we do not. They will retain these reflexes longer than they will with like propofol. When you give propofol and alfaxin and pentothal, they pretty much lose the swallow, lose the blink. You can intubate them. When you're using ketamine, they're going to retain these reflexes longer. Now, when you give a drug with ketamine, it's going to help them lose these reflexes eventually, but they do remain for a little bit, and their eyes remain more open and dilated. So when you're using ketamine, and really any anesthesia procedure, you guys have to put eye ointment in these guys, okay? Because their eyes will dry out. The last thing you want to do is cause a corneal ulcer in a patient that came in for a surgical procedure. And that is possible. When their eyes are just, imagine if you couldn't blink your eyes. You cannot blink under anesthesia. And it's worse with ketamine. So you definitely have to use some type of eye, artificial tears, make sure the eyes are lubricated. And it's not going to hurt it to put some more in. Here are some other effects that I want to mention down here underneath. Intact reflexes. Normal to increased muscle tone. They're going to be more rigid. This is why we're going to mix it with drugs. This is why we're going to mix it. You get some analgesia, but they can be sensitive to sounds and light. So you need to be careful. I would try to keep them, when they're becoming sedate with this, if you give it in the muscle, I like to put them somewhere dark. It's going to help. Now, some things that also happen, let me go back a minute. So there's some notes. Make sure you're reading the notes underneath. Their muscles are going to feel normal. The way we get away, or the way we fix that, is we give it with some other tranquilizer, like Valium is probably the most common thing ketamine is mixed with. And the tranquilizer, like Valium, is going to relax the muscles. But when you use ketamine by itself, they're extremely rigid. That's why we give it with something. It does have some analgesia. The issue is it's not enough. I mean, you're going to have to still, if you're doing surgery and you're using like Ketval or something, you're going to want to give morphine or another analgesic with it. This isn't enough to be the primary. Again, That's a nice little side effect. I'm not giving ketamine just to treat pain. It can enhance a pain protocol, but it's not a primary analgesic by itself. They can be sensory overload or stimulated, so try to be quiet, try to be slow around them. And some animals can have some bizarre behavior. Some nystagmus. We used to call this, there's an effect called the tennis match cats. You give it to cats and they go like this. And if you watch their eyes, they look like they're watching a tennis match. That's why they call them tennis match cats. And sometimes this is a disassociative, okay? Now, people, I would say one of the main drugs when I was in general practice before I went to Purdue, my boss, he was concerned about people stealing morphine. He was even more worried that we would get broken into for our ketamine. A lot of ketamine is stolen from veterinary hospitals. On the street, it's called Special K. And it's basically a hallucinogenic drug. So there are reports of people taking ketamine, abusing it, selling it on the street. Now you think about the hallucinogenic effects. And then I stick a cat in a cage and it's got that stainless steel and they're kind of looking at themselves in the reflection. So I've had cats that are staring in the back of the cage like, and I'm like, God knows what they see. They're probably looking and seeing like 5 of themselves in a reflection. And, again, it's disassociating normal neurologic function. So what would an animal normally do? Well, we're kind of disrupting that pathway. So now I have an animal that's why I said when my boss had that aggressive shepherd, he gave ketamine and Valium in the muscle. The Valium wasn't absorbed. I said it was bad enough the shepherd was aggressive. Now I have a hallucinating aggressive shepherd, which is not something you want to deal with. I'm like, he was 10 times worse because now he's basically on this really bad drug trip or something. And he's like, I'm just snapping at everything. I don't know what I'm doing because the sedative component was given in the muscle and wasn't absorbed. So I'm only seeing the effects of the ketamine. You have to give it with an appropriate sedative to get that relaxation. Now, this is a very key. Slide 86 is really telling me it stimulates the sympathetic nervous system when you give ketamine. So there's some serious cardiovascular effects. It typically increases heart rate. It mimics the sympathetic nervous system, right? The fight and flight. Increase in cardiac output, increase in blood pressure. And you're like, wow, that's great. Why don't we just give it to everybody? I mean, there's a lot of things I don't love about ketamine, but it does increase the heart rate. But this is why that it can decrease inotropy, which is basically going to potentially make it easier for a cardiac arrhythmia to occur. So if you have a dog that comes in with, or a cat, with a pre-existing arrhythmia, which is an abnormal heartbeat, I'm going to stay away from ketamine because it could make that worse. I'm also going to stay away from ketamine if I have animals that are already tachycardic. I have a hyperthyroid cat. Her heart's going a mile a minute. If I got an old frail cat for a dental and they're a little skinny and they're a little tachycardic, I don't like to use ketamine because there are some thyroid diseases that go undiagnosed. Now, I know my cat has thyroid disease. I would not give her ketamine because it's going to make her heart work harder. We don't want the heart to work harder. I also don't typically use atropine or glycopyrrolate with ketamine. You don't usually need to. Now, if I have a heart rate that, say I gave ketamine and my heart rate plummets, if you have to give atropine or glyco because they're having an emergency, you have to give it. But what I'm saying is I don't use it routinely as a pre-med. I don't routinely give atropine with ketamine for a pre-med because if I'm going to use ketamine as an induction, I shouldn't need the atropine for a pre-med. So does this make sense so far? You need to understand there's some main effects of this. And the breathing, with ketamine is what can typically be weird. Um, it can cause some respiratory depression, but what I want to highlight on slide 87 is this apneustic respiration. Now, it is not true apnea. Apneustic means apnea-like. What happens is they take a deep breath in and they wait a second and then they go, it's like a inhale, hold. Now, depending on when you're looking at your patient, you may look at them when they're in the middle of holding their breath, which looks like they're not breathing. That's why it's called apneustic or apnea-like. So ketamine typically will cause this weird breathing. I mean, it can cause severe respiratory depression or respiratory arrest if you overdose it at too high of doses. It's not, when I look at apnea, when I look at drugs that cause apnea after induction, the number one drug I think of is propofol. Probably number two would be alfaxin. Probably number three would be pentothal. This is low on my list for stopping breathing, but it does cause this weird breath holding. And here's my theory, okay? I had someone call me into a room when I was at VCA because they were worried their dog was not breathing. And when I got in there, the dog had very tight jaw tone. It had a blink, and all I had to do is I rubbed its trachea a little bit and it started going, ah, 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 and it almost started to wake up. We had to re-knock it out. The dog was extremely light. So it wasn't breathing because it was too deep. I think because with ketamine, they retain some of their swallow and laryngeal reflexes, it's almost like they can feel the tube and they don't want to breathe. It's like they're holding their breath. But I think part of that is like, what's this thing? Because sometimes when I just move the tube a little bit or I tickle their trachea, I get them to start breathing. Once they start inhaling the gas, they'll kind of start to get into a normal respiratory pattern. But when you first give it, you can see this weird breath holding, apneustic breathing with ketamine. And what you have to do is just get them under the gas. That'll wear off and they should get into a normal respiratory pattern. You also have to, there is sometimes an increase in salivation. Now, again, whenever I see excess salivation, I think I want to give an anticholinergic. But as long as you get them intubated and make sure there's no saliva, excess saliva in the endotracheal tube, and as long as they're breathing normally, I would rather not give an anticholinergic because of the increase in heart rate. But you have to watch the saliva, especially when you intubate cats. There's a lot of times someone will open the mouth and I'm getting ready to tube a cat and I have all this saliva in the back of the throat. I'll take like 3 or 4 Q-tips or I'll take like a gauze. The nice thing about Q-tips is they won't snap on you. But I'll take 3 or 4 Q-tips and I'll wipe out the back of their throat and then I'll intubate them because I don't want to drag all that saliva down the trachea. So if you go to intubate and there's a lot of saliva, just get that stuff out. Okay. The adverse effects that we have to watch. Now there's a little bit of pain. They'll get over it. But you can get an increase in intracranial, and that should say, I don't know why it cut off, intraocular pressures. Okay. If you have a head trauma or an elevated CSF pressure patient. Now, again, anytime you have a dog that was hit by a car and we're potentially worried about head trauma, if you even suspect it, we try to stay away from ketamine. If you have animals with glaucoma, that's increased intraocular pressure, we probably don't want to give ketamine. So intracranial pressure, intraocular pressure, we are going to stay away. So it's mostly, it can be given IV. There are a lot of IM protocols that contain ketamine. You can give ketamine midazolam in the muscle. You can give ketamine ACE. It works well with cats and horses because it causes this immobilization. A lot of large animal protocols There's a lot of cocktails. When we talk about large animal, I'll talk about some of the cocktails that they use. Ketamine is a part of almost all of them in large animal. If you want to combine it with a tranquilizer for a short procedure like ACE, you want to combine it with Ket-Val for induction. You can get good immobilization for large and exotic animals. So you can give a little ketamine. Ketamine is an immobilizing agent. That's why you give this drug. There is no reversal agent, though. When you give ketamine, you're going to be stuck with the effects. There's no reversal, a little bit of pain control. Ketamine is the most common one used. Interestingly enough, it's licensed for use in cats, but people use it in horses, primates, pigs. I mean, it's used in a lot of agents. It's a Schedule 3, so it's not a Schedule 2, but it is a Schedule 3, has to be recorded, and it has a high abuse potential. I mean, there are clinics that have definitely gotten broken into, and the only thing they stole was ketamine. So that's what they were looking for. IV or IM, you can use it orally in cats. It is not a tablet. You would be squirting the injectable in their mouth. So it's not like a tablet form of it. It's just squirted. It is just licensed for cats and primates, but it is used in almost every species. Yes. No, I want you to, it can be used for all species. Michaela, you can just put that. Really in dogs, now it says there's a note here, only give IV in dogs. If you're going to give ketamine in the muscle of a dog, you're not going to get good relaxation effects unless you combine it like with midazolam or a heavy sedative like acepromazine. So most of the time you do it. One thing here, repeated dosage with caution. This accumulates in the tissues. It's not like the other drugs I talked about. When you give a second dose and a third dose, remember, it's not going to increase your depth of anesthesia. It's going to increase your length of anesthesia. So you want to use it with caution. And recovery can take 2 to 6 hours. It just depends on the dose you gave and what you gave it with. So recovery is going to be, it's going to kind of depend on how long it's going to take. Mostly hepatic metabolism in dogs. I talked about that 50-50. In cats, they really need their kidneys to excrete it. And then usually it's combined with something. By itself, it's not, you can't anesthetize them with ketamine by themselves. You could only immobilize them, and they're not really relaxed. Now, the dissociative, and it's always usually combined with diazepam. Remember, ketamine is the only thing you can mix with diazepam or Valium, and you don't get that precipitate. The interesting thing, and I'm going to have to teach you how to do this math, is it's usually equal volumes ketamine, diazepam. The normal dose, I want to say, is 1 ml per 20 pounds, and that equals oops. I'm going to write this down. If you have 1 ml per 20 pounds as a dose, so if a dog weighs 20 pounds, it's going to get 1 ml total. That means a half of ml of ketamine and a half a ml of Valium. So 1 ml is not 1 ml of each. 1 ml is half and half. Does that make sense? When you give it IV, really in about 30, 60, 90 seconds. Hello. Did he go to the bathroom? Hi, buddy. Baby, hello. Sorry, had a visitor. Let's say hi real quick. Yes. Do you want to say hi? There's his loudmouth. Oh, you need a bath. You're stinky. Everybody's saying hi. Ow, he's chewing on my arm. Ah, AJ. Oh, Bo's like, hi, baby. Are they annoying? Okay, everybody heard you. Okay, we're gonna go bye-bye. Sorry. Definitely needs a bath. Hang on 1 second, sorry. Okay, thank you. Sorry. Yeah, I love that he picked up Bo. He goes, "You want me to pick up Bo to say hi?" I'm like, "Sure." Yes, my babies. The puppy, though, I'm like, "Oh, the puppy needs a bath." Might be doing that today. All right, that'll be fun. So I want to say the most common drug, probably the number one drug you mix ketamine with is Valium. Some clinics, I guess, like my two main protocols in practice were either propofol or ketamine Valium. Now, in greyhounds, before I had propofol, I would use ketamine Valium in sighthounds. So that was kind of like our number one sighthound protocol. And then when we got propofol, we kind of switched to propofol. But any like if you ran out of propofol and you didn't have any other drug, ketamine Valium can pretty much be used to induce almost anything. And you should be able to now the I have a little IM thing. You can do IM ketamine midazolam, but remember you can give midazolam IV. The advantage is you can give it in the muscle, but it can be given IV. So if you needed to give ketamine midazolam, it would be the same ratio, 1 mil per 20 pounds, which would be a half mil of each. And you would go from there. Now, ketamine, the good thing about this is it really stimulates the cardiac system. It doesn't depress it. You get relaxation. Superior recovery, I don't know if I completely, it's kind of like sometimes when they recover, if they've got some ketamine on board, they have that kind of, they're disassociated. They're kind of hallucinating. It's a hallucinogenic drug. So sometimes when they wake up, if more ketamine is on board and less like if the diazepam wears off, you may see more of the kind of weirded out effects of ketamine. Some disadvantages, there is possible respiratory depression, but they all respiratory depress. You always have oxygen nearby. It's not, again, you cannot give ketamine and diazepam in the muscle. If you do, the diazepam is just not going to get absorbed. You'll only see the effects of ketamine. But you can replace the midazolam, and that could work IM. Now, tyletamine, all I'm saying is you can't get tyletamine by itself. It's basically in the same family as ketamine, but it's only sold as tilazol, which is the two drugs together. It's a powder. You mix it with some saline, and you can store it at room temperature. If you put it in the fridge, this drug will last longer. But again, if you stick it in the fridge, it's controlled. So is anybody gonna get in the fridge? So a lot of people store it in a cabinet. You can add it with ketamine. You can do tilazol and ACE. And tilazol is really good for swine. Again, it can be used in large animal. Now, they do the same breathing like they do with ketamine Valium or ketamine. So they have that same apneustic breathing. You need to get them intubated. You need to, eventually it's going to wear off. Again, sometimes the way I get them to breathe normal, I tickle their ribs. I like rub their throat. I sometimes move the tube a little bit. And sometimes you can get them to start inhaling the gas. Once they inhale the gas and they go a little bit deeper, this usually goes away. And tilazol can be used if anybody's wanting to get into wildlife. It's a good immobilizing agent, and that's where people like tilazol. For something that you need to handle that doesn't like to be handled. Aggressive pigs do not like to be handled. We don't really use IV protocols in pigs. We pretty much give them something in the muscle. So that's when this is going to have its advantage. Oh shoot, it's ready. Okay. This is what I don't like about Tilazol, and not ketamine Valium is not really like this. You can get very difficult recoveries. So they don't recover well. They tend to be a little excited, more disassociative. You get to have more ataxia. So when they're waking up, they're trying to walk, they really can't walk a straight line. So I tend to have more issues with that in these guys. So they get more stimulus, and I typically don't use it in any of these cases down here. Hyperthyroid, heart disease, renal disease, pregnancy. If what you're picking up, what I'm putting down, is they really need to be that, stage 1 or not stage 1 or stage 2. The physical status, remember, 1 is excellent, 2 is good, 3 is fair, 4 is poor, 5 is critical. Really, if you're using it for patients in the 1 or 2 range, you're fine. Really not good for our the other patients. Okay. Now, I'm going to talk about this drug called guaifenesin. Sometimes ketamine is used with this drug. So guaifenesin is not a dissociative anesthetic. Guaifenesin is a muscle relaxant. And I believe I put that in your email. So guaifenesin is called GG, or abbreviated GG. It is mostly used in large animal. So there's a thing called double drip and triple drip that I'll get into when I do horses, and even some cattle, is we'll use like ketamine and alpha-2 and guaifenesin, and they call that triple drip. There's 3 drugs and you drip them in to anesthetize them. But the muscle relaxation in that protocol comes from the guaifenesin. An interesting little side note, if you've ever heard of guaifenesin, if you ever buy Mucinex, if you have like a sinus infection or a cold or a really bad cough, guaifenesin is in Mucinex. So in people, what it does is it helps relax the muscles and opens up, and it's an expectorant. So it helps to get stuff, Mucinex usually helps break up that mucus. And that's what guaifenesin does. So a lot of the cold medicines that you buy, or if you have a box at home of Mucinex, you look on the back, you'll see guaifenesin. It's added to a lot of cough medicines. In large animal, we use it as part of this drip for its relaxation. It is not an anesthetic, and it is not an analgesic. It is only a muscle relaxant to help relax them during induction. Usually we give it to effect. So normally when you give guaifenesin, you're going to just give it till they're relaxed, and then we usually stop giving it. So it's usually just to enhance relaxation and enhance the other drugs. And the nice thing about guaifenesin is that you get good relaxation, doesn't paralyze the diaphragm, but you get good muscle relaxation, doesn't really affect the cardiovascular or respiratory systems. Now, it can irritate the tissues. So if you do get it out, so this has to be given IV, we don't give it in IM, it can cause some irritation, maybe cause some sloughing, so you got to make sure you have a good IV, and we drip it in really well. Can cause some hemolysis if you use too high of a dose. But the way we give it is we'll give it with ketamine. They're typically going to be pre-medded with a sedative. And then what we do is, so what I wasn't mentioning earlier is you might give like the xylazine as a pre-med, and then you're going to mix the GG with the ketamine and some more xylazine, and you can drip this in. I'm trying to remember who it was, and maybe it was Sarah Callahan said that She was helping on that horse at the farm, and they did the TIVA, which is the IV anesthesia. You could just drip this in for the whole procedure, no tube, no gas. This is used a lot in field anesthesia, which I talk about with horses. Usually, and we usually have to give it pretty fast, because when I give IV propofol to a dog and I can give it slow, they might go through an excitement phase and I can push them in. I don't want a horse going through an excitement phase. They're scary enough. You want to drop them. You want to be from awake to asleep very rapidly. So we usually calculate this as a bolus and we give it in very quickly till they are like dropped. Okay. It also helps with a smoother recovery. So typically we give a pre-med with guaifenesin. Guaifenesin is not used alone. It's just to enhance our anesthesia. Okay, just to enhance the effects. Yeah, that's all for you. Sorry. Okay, so are there any questions? So let me give you an example. When you write up ketamine, you're pretty much writing up ketamine as a drug by itself. You don't have to write up, you've already written up diazepam, right? Now you're writing up ketamine. But what I'm telling you, when we use ketamine in practice, we typically don't use ketamine by itself. It's usually ketamine ACE, ketamine Valium, ketamine, guaifenesin, rampant. Do you see? Usually it's part of a cocktail or a protocol. But when you write it up, for Kitty Magic, I'll write what Kitty Magic is. Whoops, if I can type. So this is an example of Kitty Magic is ketamine, dexdomitor, usually butorphanol. It might be buprenorphine. So it's usually ketamine and dexdomitor plus the opioid of choice, whatever opioid the doctor. And most of the time in cats, they prefer butorphanol or buprenorphine. And I'm trying to remember at school if they use buprenorphine or butorphanol. It's just a dissociative, a sedative, and an opioid. Combine, one syringe, IM, asleep. In the horse, triple drip, ketamine, guaifenesin, xylazine. Induction in dogs, ketamine, diazepam. So you see my point, when you write up ketamine, you're pretty much writing up ketamine by itself. However, ketamine is used in a lot of different protocols because ketamine by itself sucks. Unless you're going to groom a cat or you have super aggressive one that you need to take some x-rays. I've seen there's better sedatives, in my opinion, than to use ketamine by itself. But like my groomer used to give ketamine to like this crabby old Persian that was basically mats from head to toe and needed to be shaved down. It would get a shot of ketamine, shave the cat, send it home that evening. And the cat would wake up, and it's all like tennis match and rigid, but we weren't doing anything painful. We just needed the cat to not move. It's an immobilizing agent. Okay. Does anybody have any questions about, and remember, tilazol is a drug sold together, which is, tilazol is like the IM version of ketamine and Valium. Ketamine and Valium IV, tilazol is tyletamine and xylazepam. So it's two different drugs, but when you write up tilazol, it should be in your Plum handbook as tilazol. And you would write up side effects of tilazol, adverse effects of tilazol, species for tilazol. Does that make sense? So I just want you to know tilazol is a component of a dissociative and a benzodiazepine, sold as one drug. So Caitlin asked a question, which is interesting. So first of all, propofol is a hypnotic. It can be used if you have an animal. When I mentioned this in the PowerPoint, it can be used if you have an animal in status epilepticus that is unresponsive to diazepam. But the problem is some people are finding when they give a first dose of propofol at induction, it's doing this muscle twitching activity. Sometimes it's confused for seizures. So I would say, Caitlin, I would just put both of those effects. It is not, propofol is not an anticonvulsant by nature. It is a hypnotic. But if you, like I said, if you have an animal that's not responding to your anticonvulsants, it can be used to stop seizures. But people have complained about seizure-like activity on induction, which normally the way that you have two options. If you give propofol and you truly think the patient's having a seizure, sometimes I've seen it as muscle twitching and people are confused. There was a case at VCA and the doctor and everybody swore it was a seizure. They decided to wake the dog up and not continue with the procedure. When we think it's just muscle twitching, we push them through with more drug, intubate them and get them on gas. But again, it's the doctor's call. If the doctor interprets it as a true seizure, they may want to stop and work up the dog and say, do we have any other issues? Well, it's difficult. You have to get your doctor. Now, normally the head and the jaw and the trunk, all of the muscles are involved in a seizure. Sometimes I've seen a dog just twitch his legs. His eyes look fine, his mouth looks fine. The rest, he's just doing some leg twitching. To me, the leg twitching is the muscle twitching from propofol. But I have a dog that's actually snapping, the eyes are doing some nystagmus, and the whole body is getting rigid. I feel like that's more a seizure. But I'm not a doctor. So whenever my dog does that, I definitely call over my doctor and be like, hey, I'm getting this muscle twitching, and see what they want me to do. Because again, it's their case, it's under their name. I would do what they want me to do, if that makes sense. I will say, I've had people say to me, they're like, this dog's having a seizure, and I've gone over and it's just some leg twitching and it goes away. I even questioned, I had one of the girls call me after that case of the dog having a seizure, and I was like, are you sure it wasn't just the leg twitching? That they sometimes, when you give propofol too slow or not enough, and they were like, no, the doctor really, really thought it was a seizure. And I'm like, well, I mean, if your doctor thinks it's a seizure, I have to listen to my doctor.
Yes.
So that's the ultimate.
I'll periodically check my phone on T3s if we.
So.
Yep,
Okay. Does anyone have any other questions? You guys are asking good questions. Again, everything we just talked about is used for induction, so there really shouldn't be a lot for, I just muted him. I don't know if Caleb was going to ask a question. If, Caleb, you can unmute yourself. I just didn't know if your mic came on as an accident, but you can unmute if you want to say something. What I was going to say was all of these categories are induction agents. The only one, ketamine, it depends on the dose and what you give it with. Ketamine can sedate an animal, and they can still swallow and blink and respond if you give it in a low dose and by itself. So ketamine can go both ways. Ketamine can be just for sedation or immobilization, or you can give more of it with another drug and induce anesthesia. So ketamine, again, I'm putting ketamine with the induction agents because that's the way we usually give it. But I want you to be aware of there's different ways to use ketamine in different, and when you look up ketamine, look in the dosing section. You'll see quite a bunch of different dosages for ketamine. So it has a wide range of use and a wide dosage range that's going to give you different effects. Does that make sense? My plan tomorrow will, the drugs will be due. And I will go through all the drugs. And then the quiz, I think I put in the email, the quiz stops here at slide 101. So it's basically the first induction drug we talked about, which I think was around slide 60 something, to this slide. Kirsten, I started making my drug homework in flashcard form. No, that's fine. I've had people send me Quizlet homework as long as I can. Sometimes Quizlet will only let me look at like 5 slides and then it stops. As long as I can access the whole document, or I can look at the whole Quizlet, it's fine. Sometimes when I've found Quizlets and I've tried to open them, it'll, it's like, buy this to get the rest of the slides. I just have to be able to look at the whole thing. And I've never set up a Quizlet, so as long as I can look at it, that should be fine, Kristen. Anyone else have questions regarding the homework? When I get this converted, I'll send this out, and I'll leave myself a note. Where did I put my pen? All right. When we were talking about barbiturates, you mentioned how it moves through the body. Yes. There's components. When I push a bolus, if I put 20 mils in a vein, 20 mils goes in the blood. Now, propanethol has a high affinity for fat. So the brain is going to suck up a good portion of that because it's a high fatty tissue. That's why they go to sleep so quick, because the brain goes. Now, by nature, some is going to remain in the blood a little bit, and some is going to go to the other fat. So what happens is when you stop giving a drug, you got a bunch in the brain, you've got some in the fat, and the blood doesn't have a lot. This is going to transfer to the blood. That's why the drug wears off, but some of that can go back into the fat of the animal. And that's why sometimes you'll get this re-release of pentothal, and that's why it accumulates. Propofol and alfaxin don't do that. I mean, they have a high affinity for fat, but they're metabolized quickly. Pentothal does not metabolize quickly, so it remains in some components of tissues. Hence, the greyhounds, when I don't have that excess fat component, more can stay in the blood. Some can go back to the brain, and that's why it keeps them asleep. So it's kind of tissue redistribution, which is kind of part of your pharmacokinetics. Does that make sense, Joycelyn? Okay. Yep. Good deal. Okay. Well, if nobody has any other questions, I will end this. You're free to enjoy the rest of your Monday. I will send out an email, and then tomorrow we will review all of the drugs that we've talked about. I will get homework entered. Don't worry. It's just drug section is long. So if you don't have anything else, the triple drip, let me type that in if you're still in here. Guaifenesin, and in all of these protocols, I wrote xylazine. I haven't talked to you about the other large anima alpha-2s because there's like romifidine. There's other, it's usually an alpha-2, guaifenesin, and ketamine. And there's something called double drip. I mean, we'll get into that in large animal, but the triple drip is usually these 3 in combination, rapid bolus, and then they're usually intubated, or you drip this in while you do the procedure. So triple drip is for large animal, Kitty magic is obviously for cats. Someone told me there is doggy magic. I've never used doggy magic, but it's a similar, like ketamine, dexdomitor, and then an opioid. And in dogs, we tend to use more pure agonists. In cats, we use the partials. So it would be an opioid of the doctor's choice, ketamine, and dexdomitor. So triple drip, horses, cattle, kitty magic, cats, doggy magic, dogs. And again, I don't usually have you guys memorize a whole lot of cocktails because there's doctors that do weird mixtures and they're like, give this drug 1 ml per 10 pounds. I've mixed these 3 drugs. So as long as what I truly care about, if you know the effects of every drug in that combo, then you know what to watch for in your patient. That's what I'm more concerned with. You're not going to have to make these cocktails. You'll have to administer them. And if you give these drugs, what do they do? How do you know they're having a problem? How do we fix the problem? How do we troubleshoot? Is this a problem with the drug? Is this a problem with my patient? That's how I want you to understand these drugs. So because these patients are under your care, you need to know what to expect. And you need to know when it's a problem that maybe is not worrisome and ones that are worrisome. So if you're grasping that from what I'm talking about, you're understanding what I want you to know. Okay. Yeah, and Sam and anybody that's still here, it takes time to learn the drugs. I don't want anybody to be like, oh, yes, right now it feels overwhelming. But then, like when you go into surgery, they give you there's a protocol sheet. I tell students before you're the anesthetist or at some point, make sure you're familiar with every drug you're using that day. And then the more you use those drugs, then when you go into practice, you're going to have probably a narrowed list. You know, if you work in a specialty center, a surgical referral, emergency, you are going to have a longer list of drugs to use. But most clinics are only using a certain set of drugs. So when you work there or you're on externship, you don't have as many to review because you're using and you get more experience the more that you use them. And you learn something every time you do it. If once I started seeing every time I give propofol, they usually stretch and yawn, and then they're usually ready to be intubated. How did I learn that? Because I started giving propofol every day. And I was like, oh, here's the yawn, here's the stretch, let me get my tube. You know, I started to see this pattern. And when you start using these drugs, you learn the patterns, you learn the amounts that are appropriate to draw up. Exactly. I need you to know why you're giving a drug. And I need you to know that if your patient's heart rate plummets, oh, I gave an alpha 2. Mrs. Landeros told me that. Oh, if I gave atropine, that's why the heart rate's so high. Exactly, Miranda. I mean, everything I've learned the basis of what I've needed to know, but it's by doing something repeatedly. So as a student, it's kind of consuming mentally to be like, oh my gosh. But once you get into surgery rotation and then you get on your externship and then you start doing it, you're going to start to see a pattern and you're going to start to say like, you know, I mean, I usually drop this amount. I usually give this much. They usually sleep this long. You know, there's averages. There's always animals that live outside the averages, but there's pretty much predictableness with a lot of what you're going to do and that you'll get more comfortable. So yeah. What I usually say, as my saying is experience. So good judgment comes from experience. Experience comes from poor judgment. So basically, I mean, you always want to try to make the best judgment possible, but if there is an error, every time I've made a mistake, I've not been fired, I've owned up to my mistakes, but I learned something from every mistake, and I've rarely made the mistake multiple times. So if I make a mistake, I've caught it because I was paying attention. I caught myself, I fixed it, and I remembered it for the next time. So that's kind of like I said, I don't, if you give a wrong amount, if you make a mistake, I mean, you're a student and you're learning, there's going to be mistakes, but you have to own up to it. Be honest. Honesty takes you very far. I don't like people that can't admit a mistake. And I don't like people that are crucified for making a mistake. You should feel free to ask questions, and mistakes happen. And like I said, the only time I've really gotten on anybody for making an error is I caught them trying to hide it, or trying to act like they didn't do it, or trying to blow it off. But I've never really screamed at anybody. I've just, I'm not in there with you guys, but I'm always there to talk about it. And you should feel free to ask questions. And that's all I got to say about that. Okay. Well, yes. And I firmly believe in that statement. The people that I've worked with and the bosses that I've worked with, it's always, when I've made a mistake, yeah, I've got a pit in my gut. When I almost cut through that dog's ear, when I gave that cat 10 times its dose of butorphanol, when I've made some of these errors, I mean, I'm just like sitting there going, oh God, I gotta go tell my boss, or I gotta go tell this doctor. I mean, the cat that I overdosed, that doctor was a royal. I mean, she could be evil. And I was really concerned, but I'm like, I have to talk to her. I have to tell her that I overdosed her cat just because of ethics. And I have to own up to my mistake. She appreciated it, and she was very nice. And I think that made her trust me more, so she appreciated that I told her, because the cat was normal. If I wouldn't have ever told her, I don't think she would have ever known. And that's where ethics comes into play. What's the ethical thing to do? Own it. But to be honest, it was 8 hours after I gave that cat's dose. It was completely normal. Nobody would have known the difference. But if that cat had a problem later, it's like my gut and my conscience, I couldn't have lived with myself knowing that potentially I did something. I got to own up to it. So, okay. Any other questions or any other life that we want to talk about? Everyone's, I hope, doing okay. The future will be bright. Yeah, you want to talk about scary? I'm going to tell you a little. When I was hired at Purdue to be an anesthesia tech, and there was 4 of us as surgery and anesthesia. I was primarily anesthesia, and I was hired at Purdue, and it was maybe just a couple months after I was hired. It was a Friday night, and at 4:00, it was like 4:00 in the evening, we still had 3 or 4 surgeries going. One was in Newfoundland that had arrhythmias. There was an orthopedic surgery and maybe another soft tissue surgery. And I was there, and all of a sudden the 3 other techs are like, hey, we got to get going. Like, one of them had plans, one of them wanted to leave. And I'm only there, like, so I graduated, like 10 months, 12 months before this, not even a year. And they're like, oh, we got to go. Christine, are you able to stay? And I was like, wait, you guys, there's like 3 surgeries going on. I would be the only one here. They're like, oh yeah, I've got the surgeons and I've got vet students, but I'm basically in charge. And I had one helper, like I had a kid, he was a pre-vet student and he was a volunteer. So it was him and I. And I'm just going to tell you, I stayed and I got all those surgeries through the night. I left at 2 him and I left at 2 in the morning. By the time surgeries got done, we cleaned, we got the animals settled. But after that night, I felt 10 times more confident than I did that day, because I kind of got thrown in. They trusted me, and it boosted my confidence tenfold. I was scared as hell. And that helper that was with me, he is now the owner of Meridian Vet Clinic, Dr. Jeff Ludrasal's. He eventually got into vet school and completed vet school, but he used to be a surgery helper. And he's a wonderful veterinarian. Just had a student get a job down there with him. He's hired 2 of our students in Greenwood. Love that guy. He actually just looked at Bo for me because Bo has conjunctivitis right now. So I just went down to see him. And we were laughing about all of our late nights in surgery. So he was just some young college kid that would come in and help us. So it was just him and I, but I was in charge. So it was scary. Like I can say, Miranda, I was scared that night. And Caitlin, I agree. Like as scared as I was, had I not had that experience, I was always leaning on them. When I was working with my coworkers who had more experience, and they were my teachers. So now I was hired under them. And I was just like, oh my gosh. And Miranda, I felt the same way. I thought, I can't handle this. I'm not going to be good enough. I've got to manage all this. But, I ended up being one of the lead techs in that department. I was there for 7 years at Purdue. And the last year I did more teaching and distance learning. But for 6 good years, I was a floor tech, primarily anesthesia, but I got into teaching classes, being in charge of I was in charge of the vet's surgery lab, the junior vet students. I ran that lab for 4 years. So like, as I got more experience and as I showed interest, they just kept like bumping up my duties and I got more comfortable, and you will be good enough. As long as, like I said, all I've asked for when I have people that work with me, you don't have to be perfect. You have to be, work hard. I don't like people that are lazy and they're on their phones. I want somebody that's willing to learn and ask questions and be open to learning. There's people that act like, I don't need to know that, or I know that. I'm like, I learned something the other day about something. Can't remember what it was. But I was like, oh, wow. Always be willing to listen. Yeah. That's what sometimes you have. And I think in a way that night, of course, nobody wants to stay on a Friday night. Well, I was young, single, and I was like, I always stayed all the time. So I always kind of was like, I'll stay late. Well, first of all, I made a lot in overtime, but I think in a way, Caitlin, they kind of pushed me into it to make sure I was confident. They're like, we're going to leave Christine. I'm sure if something was terrible, they would have stayed. But they were like, this is probably something that she can handle. So, Ace and Gerbils, did you guys ask Nemer that question? Why are you saying that to me, Kayla? I was supposed to ask Nemer something, or were you guys going to ask Nemer? I don't remember now. I forgot the Ace and Gerbil thing. Oh, that's what I learned. Oh, funny, 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 funny. So I just don't worry. I think, as like I said, a good attitude in learning and being open to instruction, open to criticism will take you far. I feel like the only nightmare people I've worked with are people that seem like they're blowing me off, or they act like, I got this, I know. And then when I find out people don't know, I'm like, don't tell me you know something and don't tell me you know something and you don't know it. I'd much rather you're honest and I will explain it to you. Because I'm also the type of person that has to be told something like 2 or 3 times. Like when I was learning, sometimes people pick things up one time very quickly. I'm kind of a repeater. I have to kind of repeat it till I get comfortable with it. So everybody learns different ways. Okay, do you have any other questions? Okay, Well, I need to get to the puppies. I'll convert this and email it out to you. And then tomorrow we'll do some review. Wait, Gabe, 1 second. Oh, hang on, I'm ending. Okay, I have to go, guys. I will see you tomorrow. Bye.